Good evening. My name is Michel Kahaleh. I'm the Chief of Endoscopy at Weill Cornell Medical. And tonight we're going to be talking about a recent paper that we published in GIE, a multicentric international registry of redo peroral endoscopic myotomy after failed peroral endoscopic myotomy. We know that peroral endoscopic myotomy has now becoming one of the gold standards for the management of achalasia. However, there is approximately 15% of patients that don't seem to respond to this technique. There's very limited data as to what we can do in those patients. But we know, talking to experts in the field, that many centers have been offering a redo peroral endoscopic myotomy on the other side. So if you've done before an anterior myotomy, you do posterior and vice versa. So we were able to actually do a study, a collaborative study with 15 centers in 9 countries, where we collected all those patients that actually underwent a redo myotomy using the endoscopic technique. Clinical success was defined as an Eckert score of less than or equal to 3 after the second myotomy. Adverse event included anesthesia-related, operative, post-operative adverse events, etc. We were able to isolate a total of 46 patients into the study. The mean pre-redo POEM Eckert score was 4.3 plus minus 2.48. Technical success was achieved in all patients. Clinical success was achieved in 41 patients, which is 85% of the patients. The average post-POEM Eckert score was 1.64 plus minus 1.67, with a significant difference of 2.58. P was highly statistically significant. 8 patients had adverse events consisting of procedural bleeding, all managed endoscopically. There were no death or major adverse events. No POEM were aborted or required surgical conversion. The conclusion of our study is that in patients that don't respond to peroral endoscopic myotomy, we should now think about doing a redo peroral endoscopic myotomy on the other side. Thank you for your attention.